Greetings. My name is Elizabeth Woodcock. I am the founder and the executive director of the Patient Access Collaborative. And I'm so pleased to bring y'all this educational event for our members, how providers are reshaping the digital experience in a consumer-centric world. We have our industry partner, Hyro, and I am very pleased to now turn the mic over to Aaron Bors, who will open up our educational webinar. Aaron?
Thanks so much, Elizabeth. Thanks for having us. Good morning, afternoon, and evening to those joining us from around the globe. Welcome to today's webinar, Healthcare 2022, co-hosted by the wonderful Patient Access Collaborative. Attendees, we appreciate you taking the time out and being here with us today. And of course, a huge thank you to our esteemed panelists in the healthcare space, Mona Bassett, Vice President, Digital Services at SEL Health, Michael Hasselberg, Senior Director of Digital Health at University of Rochester Medical Center, and David Waldman, the Chief Medical IT Development Officer, also at URMC out of New York. We're humbled that you'll be participating in our panel today. We'll be running a live Q&A at the end of the webinar, so we've enabled our Ask a Question feature via Zoom. And if you miss anything, no stress, a recorded version of this webinar will be made available. As Elizabeth mentioned, I'm Aaron Bors, the VP Marketing here at Hyro. I've spent about half a decade in emerging technologies with a focus on conversational AI. And today we'll be talking about how healthcare providers are improving digital patient experiences, how that's been catalyzed by COVID-19, and how to navigate some of these new technologies and services that are now in high demand by patients. Before we begin the panel, I'm just going to give a brief background on who we are as a company and how we found ourselves at this intersection of tech, healthcare, and the pandemic. Afterwards, we'll start our fireside chat with our panelists and finally move on to Q&A from the audience. So let's jump in. So Hyro is a plug-and-play conversational AI platform that allows healthcare enterprises to quickly add voice and chat capabilities to their digital channels like websites, apps, and call centers. We were founded in 2018 and we've raised 15 million in funding to date and have partnered with stalwarts like Twilio and Microsoft, which included winning the Microsoft Partner of the Year award in 2021. But most importantly, our team is comprised of natural language and linguistics experts, and they use their skills to delight our customers like Novant Health, Mercy Health, and of course, SEL Health and URMC. We're helping with digital front door use cases. So things like finding physicians and services, scheduling appointments, and answering FAQs over the phone or on the website. The reason healthcare providers often turn to Hyro is because conversational AI solutions can usually underperform. And that's due to their approach, which is often what's called intent-based. So that's if X, then Y. Like asking for a doctor is one intent. Asking for a doctor who speaks Spanish, that's another intent. It adds up really, really fast, and training intents comes with some serious pain points like limited customization, heavy technical investment, and time to deploy, and tons of integrations and maintenance required. So ultimately, we founded Hyro. It's a language-based conversational AI platform, which teaches AI the human language as it relates to healthcare, and then layers on all these use cases, skills, and channels. We use knowledge graphs to understand relationships in healthcare, and then we use computational linguistics to give a foundation of the actual sentence structure. And that leads ultimately to better scalability and speed. So how does that work? We automatically ingest all this data from client web pages, EMRs like Epic. We map that in a knowledge graph to understand the relationships. Then we automatically deploy those conversational interfaces like voice assistants, text bots, chatbots across all channels. And finally, we use conversational insights to help health systems optimize their content in real time. So you've got this real feedback loop going on. But now to the interesting stuff. Hyro is just a fraction of this eye-popping digital health ecosystem that's now blooming in 2021. The COVID-19 pandemic continues to be a catalyst for rampant change in the US healthcare system, including how, when, and where care is delivered. So take these stats, for example, a whopping 1,500% increase in telehealth and digital care compared to pre-COVID-19 levels, 76% of patients willing to continue the use of digital health services, and 25% of millennials already interacting with healthcare in some form through AI. So naturally, providers are ramping up their efforts to educate, expand, and optimize for this digital care revolution. 81% of healthcare execs expect their organizations to fast track further digital transformation and cut that red tape. And there's been a 112x average increase in virtual services being offered by providers compared to pre-pandemic levels. So how's this going to play out? As we near 2022, today we'll tackle subjects around this new age of healthcare, like how patients will evaluate providers in the modern age of consumer-centric care, which evolving digital experiences will be nice to have versus mandatory to compete, and how up-and-coming technologies, including the emergence of AI, will help acquire delight and ultimately retain patients. So without further ado, let's begin our fireside chat with Mona, Michael, and David. I'll ask that each panelist begins with a brief introduction about your background, your current role. And Mona, if it's okay, let's start with you.
Sure. I'm Mona Bassett. I'm the Vice President of Digital Services for SCL Health, based in Denver, Colorado. And we have 150 clinics, 8 hospitals, about 16,000 associates. And we really focus on providing care in Colorado and Montana. So my team, the digital services team, focuses primarily on consumer engagement technologies. We sit in the technology organization, and we cover things like our website and chatbots and our mobile app and our CRM. So those associated technologies that help us engage with our consumers. And my background is sort of a hybrid background. I actually grew up career-wise in marketing and moved to technology a little bit later, spent some time in financial services. So I come to the table with a little bit of a different perspective, combination of that tech and consumer experience, consumer engagement.
Wonderful. Thanks for that. And now I guess I'll just pass it in the order I see it. So Michael.
Hi, everyone. Thanks for having me. Michael Hasselberg from the University of Rochester Medical Center. Those who are not aware of us, we are a large academic medical center located up in Rochester, New York, about $4 billion enterprise. We're one of the few academic medical centers left in the country that are still partnered with our parent university and did not break away. So we roll up to one budget. We actually look at that as a differentiator. So our health system has access to our data science faculty, our computer engineering faculty, our school of music faculty, our business faculty, and we apply that expertise right into our healthcare service lines. I am our senior director for digital health, and in that role, it's my job to kind of lay out the vision and strategy to move our health system to become a digital first health system. And I also direct our health system's digital health incubator, where we have all of those faculty from all of these diverse disciplines in one place, and we build technologies. Background, I am a psychiatric nurse practitioner who went on to get a research PhD and then a business degree after that.
Fantastic. David, I think Michael may have stolen some of the thunder around URMC.
Okay, so I don't have to tell you about the University of Rochester. I am an interventional radiologist by training. I spent my entire career at the University of Rochester. I was, in the past 18 years, I was chairman of the Department of Radiology and Imaging. I would say in terms of medicine, radiology and imaging is sort of at the forefront of all of healthcare IT. The rest of health care right now is sort of catching up to where imaging was or is. Actually have passed it. Now I got a really cool job. I am an associate vice president of the medical center, but I am also the chief medical IT development officer. What that means is basically I get to see all the cool IT technology before it gets put into the medical center and decide what we should do and where we should go, sort of help Mike determine our strategy and figure out what our next steps are.
Oh, great. Fantastic. Okay, so I'll kick off some of the questions that have been either submitted or just designed by us as a panel. I guess, David, maybe I'll start with you actually, since you just now introduced yourself. What's one of the key digital patient access, care, or delivery challenges that endured during 2021? And how might that challenge have been unique to your health system?
So people didn't want to go to the medical center. They didn't want to go to the doctor's offices. So we had to pivot very quickly and figure out how we were going to develop a telemedicine, telehealth program. Although we had the backbone of it, we really didn't have our primary care docs on board. And that was sort of our number one primary thing, is how we can develop a telemedicine program, which we cobbled together. It was nothing out of the box. So just like every other institution, you had to figure out how to do that. And because we are on Epic, we are an Epic shop. We are an Epic shop first, but Epic at the time was not interested in creating a video telehealth platform. And so that was our biggest challenge, and that's what we attacked first.
Great. Mike, do you have anything to add to that? Or do you have a different challenge actually through a different lens at URMC?
I think David spoke, very articulate around our telemedicine struggles. One of the other struggles that we had was in terms of patient access and self-scheduling. Pre-COVID, we didn't have really any online scheduling offerings. And it was, a very archaic process. You called a call center, which was understaffed and has a lot of turnover. And you got, press 1 if you want to talk to this person, press 2 if you want to talk to this person. And then patients sit on the phone for 15 minutes and then finally talk to somebody and, get an appointment possibly with the right provider. So that was, right after telemedicine, we needed to tackle that problem and really build an online self-scheduling portal that was connected into Epic through our patient portal.
Wow.
I will say Michael's making it sound a little easier than it is, because our portal adoption was not quite what it should be. So one of our first tasks was trying to get our portal adoption up so that we could actually use self-scheduling.
Wow. So a lot of changes very quickly off the heels of COVID-19. How long do you think it would have potentially prolonged the creation of those systems had it not been for COVID?
I think we would have started doing self-scheduling. We would have started building that out because our competitors in our market were already starting to do that. As David said, we did have telemedicine. I think we were doing about 5% of all of our ambulatory visits prior to COVID was via telehealth. Within 2 weeks, that went up to about 90% of what we were doing on the ambulatory side through telehealth. And I don't think that would have happened without COVID, because we needed some of the payer and government regulation loosening for that to push forward. But I think the self-scheduling, maybe it wouldn't have happened as quick, but
Right.
we would have done it, I suspect, over the last year.
Really interesting. Mona, did you have, I'll pose the same question to you, or feel free, we can move on to a different question, but did you have any specific digital challenges that arose during 2021 or throughout the pandemic that's been unique to SCL Health?
Yeah, it was interesting. I'm not sure if it's unique, but we did have many platforms in place. We had online scheduling, we had video visit platforms, we had access to all of those, our patient portal. And what we found is, before times, as I call it, before times, our virtual platform sort of had cobwebs on it. People really didn't use it. And I think it was a combination of patients really not being familiar, providers also having some concerns about using it. And so we had probably a few dozen video visits a month prior to COVID. And afterward, when our clinics were closed, basically, except for emergency care, there was no other choice. People had to go online if they wanted care. And so that sort of forced adoption, what we found is both providers and patients tried it and they really liked it. And they saw how easy it is, how convenient. So we went from, again, just a few dozen video visits a month to, over 10,000 to 15,000 a month, almost immediately, which was really a huge jump. And granted, we don't see as high of usage of video visit because it's not really required, but we are still seeing pretty high levels of usage because, again, so convenient for many of your typical conditions and visits that you want to have with patients.
Oh, fantastic. Congrats on the impressive growth in that space. And it echoes what some of the stats we've seen before from SIA partners, the 1,500% growth in telemedicine since the beginning of COVID-19, which is just absurdly high. And speaking of before times, I think it's a great segue into the next question, which is, what is the biggest change you've seen in the way that patients now choose and evaluate their providers from the before times till now? And has it been difficult maybe to meet some of that newfound demand?
Yeah,
You want the answer? Go ahead, Mike.
I could jump in on this one. I think the biggest driver to the consumerism change that we're seeing now wasn't, because we're all forced up on Zoom through all of our lives now because of COVID. Yes, that helped, but I don't think that was the biggest driver. I think the biggest driver was, COVID hits, 53 million people ended up unemployed. And when you break down that 53 million people, 17 million, around 17 million ended up on insurance of another family member, 13 million ended up on Medicaid. The majority, 23 million, ended up being uninsured or ended up on a high exchange deductible market. And so now patients are now more thinking about price and price transparency and, being a little bit more savvy on what I'm going to spend my money on. That was the opportunity for retailers to enter into the healthcare space or really, beef up their markets. So, you see Walmart, jumping in with Walmart Health and CVS and Walgreens. And, we all hear about Amazon Care and Best Buy, and now Dollar General just hired a CMO and is moving into that retail health space. That was a big eye-opener, I think, for our health system. And now to really meet those demands of our consumers, we need to really start thinking kind of through a retail lens. And that is not something we do well as a health system, and especially around price transparency and all of those competitors. It's like a la carte. You want a video visit, you're going to pay $60. You want an e-visit, you're going to pay $25, and you're not even going to go through your insurance. So starting to kind of think through those lenses and change the way that we think about how we get reimbursed for our services is probably the biggest task ahead of us at URMC as a health system.
Yeah, I think that comments are so interesting. Just that, that move to consumerism was, already happening. Obviously, this accelerated it. And you see some of those retailers, getting into our business, but it's going to be their business and they're going to do it well for those specific types of visits. Hopefully we will still be able to, provide confidence and trust because of the nature of our health systems. But if you look at, experience and how important that is, I mean, that's certainly something that we have seen accelerate. Certainly we offered many self-service options online, but it wasn't enough. It was basically, we had to offer even more ways for people to access us. If you create 1 ounce of friction in that process, someone is going to leave and they'll be like, this is going to be easier at Walmart or soon, Dollar General. But it's really looking at it from a consumer perspective and understanding that healthcare doesn't get a pass anymore. We may have gotten a pass previously, but these past, almost 2 years have just eliminated that pass. So we really have to focus.
Great. David, do you want to add to that?
No, I agree. I think really, if you look at it a couple of years ago, it was all about quality and health grades and scores. And while that is important now, ease of access is the primary driver. And you have to make sure there are no barriers to the patients or you'll lose the patients. No question about it. And we do have, everybody's busy, right? And we've had a shift that we really have to figure out how our providers can become more efficient. So even though there's been this change to telehealth and we have all these IT tools, as a system, we have struggled a little bit with workflows and how to make our providers more efficient to deal with all of the changes. So it's almost like technology is changing faster than the healthcare system is changing to meet those new technological advances.
It's again a perfect segue, I think, into the next question. All those answers, I think, fit perfectly with the theme of what this webinar is, which is about the retail-like experiences now that patients will expect in 2022 versus what didn't exist prior to 2020 and the pandemic. But building off the last question, so which digital health strategies and tools are being implemented to deal with some of those challenges and to help maybe speed up the readiness of some of these providers? And are there any success stories that you'd personally like to share that you've heard of in the industry, not just in your own health system? I'll direct that one to Mike.
Yeah, great. I think the story of how we actually got connected to your company, Aaron, is an example of a success and interfacing with the consumer in a way that they were looking to be, connected to. So COVID hit, and our first major problem that we ran into as a health system was our COVID hotlines that we stood up, which were manned by our emergency room and urgent care physicians, got flooded with phone calls, with essentially worried well calling in, wondering if they had COVID, but the folks that actually had COVID that we need to get through the hotline couldn't get through. This funnels down to my shop, the innovation shop, and said, we need a technology, we need to stand it up fast that can help triage these phone calls. We did some really quick user testing, and we found a chatbot, an interactive chatbot was what consumers preferred to interact with for that triage process. So we built our own chatbot that we stood up for COVID for that purpose, and it did what it needed to do. It cut our call volume down by 50%. The next problem we ran into was, how do we keep our employees healthy? Because they're contracting COVID from each other, and we needed to screen them efficiently every single day. So we repurposed that chatbot that we had success patient-facing for our employees and deployed it across the entire university. Every day, our employees had to interact with the chatbot for symptom checking. Now, our chatbot is not as sophisticated, does not have the natural language processing components, and doesn't scrape data from all the different sources that the high road chatbot does. We knew if we really wanted to move away from our call center, we needed a very nimble technology that could interact with the patients and understand what the patient is saying back to them. And we got connected to Hyro from our experience with the chatbot, your experience from the chatbot, and we thought it was a perfect match. And so one of the early things that we onboarded was Hyro to put onto our patient website, to patient-facing website, to answer frequently asked questions, to help with find a provider, to help with that scheduling process. And I think that gives a good example of how we built our own solution, got us to a point. We did the market analysis and knew that this is what our users wanted. And then we found a great company like yours to help us take us to the next level.
Wow, fantastic. First of all, to everyone listening, I just want to say I didn't pay him to say any of that. So just
Now I have to add a little bit more, because Hyro was my project, and Hyro taught us a lot. And what it taught us is that our knowledge on the web was not what it needed to be, because it was not giving proper answers to the patient's questions. So it's not something, any chatbot, it's not something you could just deploy and say, oh, this is going to be great and everything's going to work hunky-dory. It does take a lot of nurturing in order to make it work the way you want it to work. And a lot of learning, it may do this, may do that, but we needed to do this. Like, we want to be able to get our patients to a live chat or to transfer to a voice call. And so although it starts with A, you may end up at point Z before you realize it, to get it working the way you actually want it to work and need it to work.
Definitely. Thank you both. That's amazing feedback. So yeah, Mona, maybe do you have, I mean, you're also a Hyro client, but do you have other examples of digital health strategies and tools maybe that you've run across that you've been impressed with, that have helped you to deal with some of the challenges, different ways in which patients are trying to engage with healthcare?
Yeah, I think silver lining of the pandemic was that we had a roadmap with many of these items on it, and we got to move really fast on it and get all our approvals in place and launch new things, enhanced versions of old things we had, brand new things, obviously chatbots. We launched a brand new provider search and scheduling tool that really gives a retail kind of shopping-like experience for shopping and scheduling with providers. We also launched a new mobile app during that time, and that enabled people to self-service, not have to get stuck on phones on hold, really giving people opportunities to do all this stuff by themselves if they wanted to. And one of the, I think, more innovative things that the team had to come up with is when COVID vaccines were available, but there weren't that many available back in the day. And we had to set up a way to get people to, if they wanted to sign up, and we would contact them when the vaccine was available. We had to provide something that was not, does not require a portal registration. And so we ended up getting 200,000 people sign up on this CRM form. And once vaccines became available and we needed to contact people, it was going to be impossible, obviously, to call all these people or contact them in some way. So, and many of them probably had already gotten their vaccine somewhere else. So we put together a process where someone would get a text, they can say, or an email, and they can say, yes, I still want to be on this list and I want a vaccine, or no, I don't, you could take me off. I think immediately we got rid of maybe like 60,000 of the people. And then those who we wanted to connect with, we were able to give them a click to call basically, and they would contact us and we'd be able to set them up. So that saved so many hours of contacting people. And I don't think there would have been enough people or enough hours in the day to be able to get back to everybody. So that was something that worked out very well for us.
Oh, fantastic.
I do think, though, I think that if you look at technology, again, this has to do with pivoting and moving it all forward. So we stood up a telehealth telemedicine platform quickly, but as Michael said, it was pretty immature and our doctors didn't like it. So I think that moving forward, clearly, we're in the middle of standing up a much more mature telemedicine on-demand visitation, patient visit platform than we ever imagined doing before. And so it really has pushed us not only to stand up the technology of today, but to think about what we really need moving forward.
Great. And again, a nice nice movement into the next question, which is looking forward, thinking about these evolving digital front door experiences. So some of them patient portals, accelerated scheduling, self-service registration. If you can, name one that's nice to have versus one that's truly mandatory moving into 2022, or at least one out of the two. But yeah, I think David, start with you.
I think that on-demand telemedicine visits is something that we really need to be able to compete. Clearly, that is something we have done. We also have put in electronic registration, and you can do it both on the mobile app and at the physician's office. I think when you look at technology like geofencing, where when you're driving to your doctor's offices, that all of a sudden they know, oh, you're there, you're in the parking lot. I think that type of technology is something that's nice to have, but I'm not really all keen on throwing it out everywhere. It's doesn't seem like it's worth the effort, and I'm not sure how many people really have their GPS turned on their phone actually to use it. So that's kind of my opinion. But
interesting takes. Okay. Mona, do you have different ones entirely, or do you want to agree, disagree?
I have a slightly different perspective. I read a stat recently that 60% of Gen Y patients would switch to providers with better online access. So just like that, you create some friction, you've lost them, they'll go to your competitor across the street and you've probably lost them forever. So when I thought about, when I think about this question, I think about what do people expect in their, the other parts of their lives when they shop online, when they deal with, an airline or a bank? What are the things that they're expecting there? And those are the things that I say we have to have. They're table stakes. So live chat, chatbots, self-service, being able to schedule your own appointments, video visits, all of that. And there are still things that we need to put in place. But I think about it, if they can do it at Nordstrom.com or Target or Walmart, we should probably be able to do it as well. And I think about, I always look to retail because they're ahead of us, always ahead of us. Nordstrom launched something new during the pandemic where you could take a picture of something and it would find that thing on their site. So it sort of replaced you going to the store and talking to, one of the employees there. I'm looking for something like this. So it's take a picture, you upload it. So I think about, how something like that could translate, and it could translate like, I'm going to take a picture of this rash. I'm going to send it to you. And please tell me if I need to come in. So, again, they seem like they might not be analogous, but they are. And if they're seeing it in those spaces, we should be ready to do it as well.
Nice. It sounds like a great use case. And Michael?
It's kind of jumping off of what Mona said. I think to me, the top priority must have is actually an enterprise data warehouse. And why Nordstrom and why Amazon can predict what you want to buy before you even know you want to buy it is because they have really robust data warehouses. And they have all of the pictures of all their clothing in the store, and they can do computer vision and kind of match real quickly to that's the item you want and take you to that website. We don't have that in healthcare. Our data is all siloed all over the place. Our EHR data has a ton of noise in it. So to do machine learning and AI in it is very difficult and not reliable. Our claims data is in a separate warehouse. Our supply chain data is in a separate warehouse. Our patient satisfaction data is in a separate place. To become, the Amazon Prime health system in the future, you need the data in one place. You need to have the data cleaned and all matched with a good data library. And then once you have that, then you can actually start building that smart health system of the future that's AI driven. So you can actually have that experience that Northstar provides. It isn't the technology. It isn't taking a picture with the phone. It's the data generated behind that picture.
Wow. So fragmented data sources, that's the number one, I guess, source of limitation for these types of deployments.
For doing AI in healthcare, it is. I mean, where AI is successful is in small use cases. David can probably speak very eloquently around radiology. That you can do AI really well with radiology and images. You have a lot of data there that's standardized, but to match the right patient to the right provider at the right time, at the right place, and to do that very cost effectively, essentially creating a digital twin of your patient, that we are, as in healthcare, we are far away from. And so in our health system, in parallel to our digital health strategy, we have an enterprise data warehouse strategy that's also being deployed at the exact same time. And that, to me, is that is the big must-have.
Wow. Really interesting insights. Mona, David, do you have anything to piggyback off of what Michael said?
I'm slow clapping over here, Michael. I totally agree.
I'm with him. I mean, it's our strategy. Clearly, we agree. So
Sure.
I will say that AI in imaging, although Michael says we have a lot of data, we do have a lot of data. I do think this is my own philosophy, that AI in medicine is going to be much more appropriate for non-clinical activities. So for clinical activities, everybody thought, oh, this is going to be great, but it has much too high of a false positive rate, and just in imaging, and adds way too much work to our providers right now. We use a lot of it. I'm just not sure what its future is going to be yet in things like billing or determining what the best provider for you is. Clearly, AI has a huge place. I'm not sure, again, in imaging, where it actually will fall.
Very
More to come.
Stay tuned for 2022. Great. So on the subject of AI, I wanted to actually ask if there are any use cases or digital strategies that we've discussed today where AI will play a role sooner rather than later. I think, David, you've already answered that, and you, Michael, as well, to a degree. Mona, do you maybe have any different take on how AI will be used at SEL Health, or have you heard, amongst other healthcare providers, of places where AI is being successfully used in certain use cases?
Yeah, I think from a consumer perspective, many of our organizations are using AI to help with the self-service, help people feel empowered that they can get what they need done without having to contact us. I do think AI can also kind of work behind the scenes. If you think about, robotic process automation, and, you think about our labor market right now, I mean, it is tight for everybody, every industry, every type of job. And, again, we can't hire enough people to be answering phones, to be reaching out to different organizations for pre-authorizations and things like that. So we're exploring ways we can use robotic process automation to do some of those behind the scenes activities. And what this hopefully will do is it will free up our associates and staff to be able to handle the more complex questions that patients have, really be able to add value to that experience. I think we will always, we will always have a phone channel. We will always, have brick and mortar. We've got to provide options for people to engage with us the way they prefer. And again, one of the ways we can support that effectively is by trying to automate some behind the scenes types of things to free up people's time.
Nice, really interesting. And just on the subject of the labor shortage. So obviously there's a labor crunch, clinician shortages, there's burnout, there's high turnover, translates to a ton of cost nationwide for trying to replace that labor. So, I mean, how will that emerging tech help in the short term? And is there any fallout we can expect maybe in the future from using AI to replace more first touch resolution use cases and those types of things? Just building off of what Mona said, if anyone wants to jump in.
Not really AI. I do think it is robotic automation of repetitive tasks. I think that would go a long way to helping our labor force. And we need to figure out how to use it a little more effectively. I do think just in terms of definitions, people throw around the term AI an awful lot, and some of it is valid and some of it is, well, that's not really AI. So, and that's not a criticism of anybody. It's just the way it's grown up. But I think true AI certainly has potential to help in healthcare. I think we're figuring out where the best place is for it, but I do think repetitive automated tasks is something that we need to look at very, very quickly. And if you do look at the labor force, potentially that will decrease the necessary labor force, potentially, but it also will allow the people who are working to perform at a much higher level than they're currently performing.
Wow. Thanks.
Yeah, I'll give you an example of where AI may have a major impact on workforce in the future, and probably earlier in the future than later, would be in the hospital setting. So one of the things that we struggle with in the acute setting is patients being at fall risk, and how health systems or hospitals have handled that traditionally in the past is we've essentially put a one-on-one with the patient. So literally we will put a live human sitting next to a patient or sitting outside of several patient rooms who are on fall risk to watch to see, if they're slipping out of the bed so we could intervene quickly. Now, here's the scary data on that. We know that only about 60% of those falls will be caught with that live human sitting right next to that patient on the bed. Now, the next kind of level of technology strategy to fix this problem is what we call telesitting services. And telesitting services, essentially you put cameras up in patients' rooms and you have one-on-one, maybe watching 10 rooms at a time with a Zoom camera, but it's still a human looking for those behaviors that could lead to a fall. Now imagine a system, however, that's generated using computer vision. Now, if you had cameras up in the room, you could actually have the computer starting to predict and pick up the behaviors that may lead to a fall. Then you have the computer watching 200 rooms at a time and only flagging the rooms for that human user to look at the cameras that there's risky behaviors happening, that one human now can cover 200 rooms and notify the nurse on the floor. Now that's an area that the data is fairly contained, and we have mechanisms like computer vision that could get us there, and that could really have a major impact on our hospital shortage, specifically with nursing aides and nurses that we're significantly struggling with in the hospital. So I think that's a case example that I think people will see in the next year or so.
Yeah, that's a phenomenal use case. I was actually going to ask if it's something that's close to being adopted by URMC or SCL Health, or if you've even seen that deployed.
So our university, and hence why I gave that use case. Yes, we are actually in the process of working with a startup company and partnering our data science faculty with that startup company to test and build that technology out.
I will give you one other use case, which certainly I think adds to the quality of how we practice medicine. So we use AI for all of our head CTs, and what we found with the AI head CTs to look for bleeds within the head is that if a radiologist looks at it, it doesn't necessarily add to the positivity rate. But where it has a huge impact is the outpatient who may get their head CT at an outpatient facility on a Friday night, where previously that study may not be looked at till Monday. If the AI does find a positive finding, AI then changes our work lists and adds it to the top of our radiology work list so that those patients can be identified much more rapidly than they had ever in the past. So that is a very simple use case for AI, where people originally thought AI would be great in the hospital, but really it turns out it's much better on the outpatient side, where those things may not have been looked at immediately.
Wow. Nice. Amazing examples, use cases. Before we move forward, anything else on this subject? Great. So I think that about wraps up the time we had for the fireside chat. Although it's in no way done with the panel, we're going to look at some questions people have been asking and take some of these. So I'll just start with one of the first ones I see here. So many of the current solutions require entry through the patient portal or another platform that requires an email address, broadband access. These have been identified as facilitators of the digital divide. As academic medical centers and children's hospitals, how can we ensure that we are not perpetuating inequities through our digital health strategies? Very interesting question, a topic we definitely didn't have time to cover today. So I guess we can kick off the Q&A with that one. If it needs repeating, let me know. I'll run back.
So Michael and I recently were awarded an FCC grant. We live in an area where we have a dense population around Rochester, but we have a very distributed population within our entire catchment area. And so the question is how to get broadband access to those areas. And clearly that is one of the big pieces that we do need to tackle. And we wrote this grant in order to try to get some more technology into these areas that are depressed and may not really have the resources in order to use this particular technology. Interestingly enough, we're also working on some other ideas in order to bring some of the technology to where the patients go. So if you think of what type of stores those patients might shop at, can we bring some kind of telehealth to those areas so that they can then get the medical needs that they need? And so clearly we are thinking about that. That is number one on our list, how we can possibly get the technology out to those areas. The other big thing is that we believe that the future, a lot of this technology has to be in the area of home care. So how can you actually get that home care information back to the providers who can help those patients to try to keep those patients out of the hospital and to decrease length of stay?
Brilliant answer. I think you covered even more than the width of the question. And yeah, that's congratulations on the grant, and pretty incredible work you're doing. Dave, did you want to add to that, or sorry, Michael, would you like to add to that?
Yeah, the other thing that we have learned is actually in the state of New York, we actually have really good broadband, and actually out in our rural areas. Now, that's not the problem. The problem that we have is some of our patients in high disparity areas cannot afford internet. And the only internet access that they have is through their data plans on their phones. Now, we've quickly learned from our market is everyone has a smartphone and they have data plans on their phones, but to use a web-based app is very different than doing a video conferencing stream for telemedicine onto your phone. That eats a ton of data up. So we've seen with our, maybe underserved high disparity populations that text-based applications, phone-based applications, a lot of engagement in those types of technologies, and some very simple web-based applications that don't eat a lot of the data plan up. We'll get higher engagement through those types of technologies than, trying to do a telemedicine appointment into a patient's home on their phone when that's going to kill their data plan.
Yeah, and I think this is a big issue in many communities in Colorado and Montana. We have many rural communities that struggle with the broadband access. What I have found is partnerships, these public-private partnerships are extremely important. For example, I sit on the Colorado eHealth Commission, and there are many different members from lots of organizations, providers, other hospitals, technology companies, all types of organizations. And we have been working on a health IT roadmap. And one of the biggest initiatives is bringing broadband to those areas to enable access, data sharing, information sharing, all of that, because it really is a foundational need. Also, one of our principles is providing people options to connect with us. So if they're not able to do a video visit, we can do a telephone visit. So it's not as probably as easy, but it can be done, and we try to fill some of the gaps that way as well.
Great. Wow. So it sounds like an issue that's being focused on by both SCL and URMC. If you could give, I guess, just as one of the final questions, and then we'll see if we have time for one more, but for all of the digital innovation IT leaders listening in healthcare right now, if you can give one critical piece of advice moving into 2022 from just based on your opinion and your experiences in the last couple of years, what's a key piece of advice you'd give moving into 2022 for how to really revamp their digital strategies to help be ready for these new patient demands that are coming up? Just kind of for a summary for the session we had today. Whoever wants to start can.
I think for me, it's in being in technology, it's sometimes easy to chase the shiny object. There's a lot of really great technology out there, so interesting, many companies doing different things. So always focus on what your patient and consumer need is, truly understand that, and offer options for them to engage that really work for them.
Great. Michael.
That was a great answer, Mona. I think on the healthcare side, the ability to be agile. We're not typically agile in healthcare, especially at academic medical centers. We tend to take the waterfall cascade approach. And to move quick to meet our patient needs, you need to be nimble, you need to be agile, and it's okay to fail. Just you need to fail fast and then quickly iterate on that.
Sounds very startup-like, the advice you've given, so we can relate. David.
Well, I think a lot of it is like a startup, right? Because we're all sort of starting up, right? We're all trying to figure this out.
Sure.
I think my piece of advice, and one of the things that I've always been frustrated with throughout my career, is that if you look at the big companies, if you look at the Microsofts or the Apples of the world, instead of optimizing what they have, they always try to get you to move on to the next greatest thing. And I think as a healthcare system, if you look at what you really need and the technology you have, most of us have a lot of the tools that we need. We just need to figure out the best way to use those tools. And IT is not always your solution. So along with the IT, you have to remember the workflow, how we operate and how we get through the day. And that is, to my opinion, the workflow is much more important than the IT solution.
Fantastic. And the last question, just I don't want to miss, but Barbara asked Mona directly if SCL is also an Epic shop. So I thought maybe you can.
Yes, we are an Epic shop.
Okay. And then the last one was, what is your % of those using the portal for primary care versus specialities? If you know that off the top of your head. I think that one was also to Mona, but I'm not sure.
I don't know off the top of my head the difference. Overall, we're I think a little bit above 50% active users, basically of our patients. I am willing to guess that I'm pretty sure that specialty is smaller on that. Primary care, very highly used. So as you get into some of the specialty experience and inpatient experiences, is going to be lower.
Okay.
We have found the exact opposite. We have found that our primary care docs run about 55%, and our prized child is orthopedics, who runs about 90%.
Wow. Okay. I guess it differs across the board. Very interesting. All right. So in our last 60 seconds, I'll just use the time to give a big shout out to the panelists. Mona and David, Michael, you've been great. Fascinating discussion. Thank you for bearing with my intro and really appreciate your time today. Elizabeth, thanks for putting it together, and for Patient Access Collaborative for hosting us. And to find more out about Hyro, please go to hyro.ai. And feel free to reach out to learn more about conversational AI and healthcare, or just our tech in general. And yeah, have a great rest of the week to everybody. Thanks.
Thank you.
I know.
Thank you.
Thank you.